My name is Katie Connor. I've been working in PA education for about 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. Today, we're going to talk about our endocrinology unit. This is part of a 13-part series to try to make didactic year a little bit easier and help you ace your boards. So let's look at our objectives for this unit. Not a lot of objectives in this unit compared to some of our other units, but a lot of these are theoretical diseases. So you have to kind of think through the layers on what's happening with the hormone there. So I'll try to simplify that for you. The first thing I want to start with is, what is a normal feedback loop? And I want to set this slide up for you. So what we're looking over here on the right, that's going to be the hypothalamus. It's a part of the brain that acts like a thermostat to regulate our hormones. Then we have the pituitary gland, and then finally we have the thyroid. So I want to use this as our setup of what a normal feedback loop should look like. The red strip on the top is going to act as our bloodstream, and then the green circles would be an example of T3, T4. So T3, T4 in the bloodstream are going to go into the hypothalamus, which is our thermostat, and it will upregulate or downregulate hormones depending on what levels we need. So the hypothalamus will release thyroid-releasing hormones, and that will act on the pituitary gland, which is our second layer down. The pituitary gland will release thyroid-stimulating hormone that acts directly on the thyroid. And then the thyroid itself will produce the T3, T4. And then this is the example of the complete feedback loop here. So you have tertiary, secondary, and primary levels. Now that is a normal feedback loop. Let's look at an abnormal feedback loop. So same setup as that last slide. The red strip is our bloodstream. We've got the hypothalamus, the pituitary, and the thyroid. Let's say that we have some dysfunction going on and it's just not working correctly. If it's at the level of the hypothalamus, we classify this as a tertiary dysfunction. If it's at the level of the pituitary gland, we would classify this as a secondary type of dysfunction. And then at the gland itself is classified as primary dysfunction. So tertiary is at the hypothalamus, secondary at the pituitary, and then primary is at the gland itself. And in this example would be the thyroid. Let's talk about some of our pituitary conditions. But before we get into those, I want to talk about what the hormones are that are made and secreted by the pituitary gland. So let's start on the top part of this chart here. We're going to talk about the anterior pituitary, or the adenohypophysis, that actually makes the hormones that are secreted. We'll start with growth hormone. This is released by growth hormone releasing hormone, acts at the liver to release IGF-1. This will stimulate bone and cartilage growth and also causes insulin resistance. This is inhibited by somatostatin. Soma means growth and statin means stop or slowed. So somatostatin means to stop the growth. Thyroid stimulating hormone, or TSH, is released by thyroid releasing hormone, and this acts at the thyroid gland itself to release the T3, T4, like we saw in our example. This will regulate our metabolism, our heart rate, and our thermoregulation. T3, T4 will adjust the levels of TSH. So if they're too high, TSH will go lower. If they're too low, TSH will go higher. Adrenocorticotropin, ACTH, is released by corticotropin releasing hormone, and it acts at the adrenal glands to release cortisol. This will increase our glucose level, but also cause immunosuppression. Elevated cortisol turns itself off, so turns down the ACTH. Prolactin, or PRL, you may see that abbreviated, gonadotropin releasing hormone, is what causes the release of that. It works at the breast to stimulate lactation. It's turned off by dopamine. And then finally, luteinizing hormone and follicle stimulating hormone. These are released by gonadotropin releasing hormones, work on the ovaries and the testes to cause ovulation and spermatogenesis. And these turn themselves off. So if LH and FSH are too high, they go lower, and kind of the same. The posterior pituitary we call the neurohypophysis. This does not make hormones, but it stores hormones. Vasopressin and oxytocin are the two that are in the posterior. Vasopressin is also called ADH, or antidiuretic hormone. This is released by hypovolemia, and angiotensin II will trigger the release of ADH, and the target is going to be at the kidneys. This will increase water absorption in the kidneys, decrease serum osmolality, and increase urine osmolality. This will be inhibited by ANP. Oxytocin will be triggered by nipple stimulation or cervical distension, because remember that this is what helps us for the lactation hormone. This will work at the uterus and the breast to cause milk ejection and then uterine labor contractions. This is inhibited by dopamine and progesterone. So that's kind of our overall view of what's going on in the pituitary gland. The first disease we'll talk about is called an incidentaloma. It's something that's found incidentally when somebody has a brain MRI. Normally, these are asymptomatic, but if they're big enough, they can cause a headache. Also, if they're big enough, they can cause an ocular palsy in the extraocular movement. So you can have kind of a disturbance in those extraocular movements. They can also compress the optic chiasm, so they can cause a bitemporal hemianopsia where you can't see on either side there. So by definition, this is a pituitary tumor that's found incidentally. If it's a microadenoma, it's smaller than 1 centimeter. If it's a macroadenoma, it's considered larger than 1 centimeter. And the diagnosis for this is going to be an MRI. It was found incidentally. If it's non-functioning or they're asymptomatic, you can just observe that with an annual MRI. If they are symptomatic, you can take that out. It's called a transsphenoidal adenectomy, where they actually go in through the sphenoid bone and pull that out. A prolactinoma, the board question on this one. The prolactinoma is the most common pituitary tumor. And prolactin inhibits estrogen, so patients, if they're female, may present with amenorrhea. In males, it will cause erectile dysfunction because prolactin will inhibit testosterone in men. Galactorrhea can happen, so this is milk production that's unassociated with childbirth. This is very rare in men. If it's big enough, just like in our incidentaloma, it can cause that bitemporal hemianopsia. You can see in that bottom picture there to the left, that's what their visual fields will look like. By definition, this is a pituitary tumor that secretes prolactin, and it's the most common pituitary tumor. The lab finding that we may have for the diagnostics for this would be a prolactin over 100. You always want to rule out pregnancy, so you would do a HCG test, beta HCG, and then a brain MRI is going to be definitive for this. Remember that prolactin is turned off by dopamine. So the dopamine that inhibits that prolactin, we're going to give that as a form of a dopamine agonist, something that works like dopamine. So bromocriptine or cabergoline would be the two examples of the medications that we could use. Transsphenoidal adenectomy, where again, we remove that pituitary gland, is also a surgical option. Panhypopituitarism. This is where you have a decreased or absent production of all of your anterior pituitary hormones. So symptoms of hypothyroidism, hypoaldosteronism, infertility, hypogonadism, growth failure, and delayed puberty, because all of those hormones are being affected. So a reminder again, that's LH, FSH, GH, TSH, and ACTH. Now, your posterior pituitary, reminder, your oxytocin and your ADH, the secretion can be affected, but not the production, because remember that the production is actually occurring in the hypothalamus. Things that can cause this: a pituitary adenoma causes ischemia or death of the normal pituitary tissues. Sheehan syndrome is one that is related to a very traumatic labor that can cause an infarct and cause death because of a vasospasm. Apoplexy is infarct due to some kind of traumatic brain injury or a stroke, a CVA, cerebrovascular accident. You can have a congenital loss of the pituitary gland, so something called empty sella syndrome. Remember, the sella turcica is the area where the pituitary sits. An infection can also cause this, something like meningitis or encephalitis that affects the brain tissues. We diagnose this with a brain MRI, and on labs, you're going to have decreased levels of TSH, cortisol, insulin-like growth factor, luteinizing hormone, and follicle-stimulating hormone. The way that we treat this is we take out that pituitary gland if it's dead. So if you have an infarct or you have an adenoma, you can remove that. But you do have to replace the hormones on a lifelong basis. So prednisone, levothyroxine, testosterone, estrogen, and somatropin. Dwarfism. We're going to now talk about the diseases of growth hormone. The most common cause of this is actually unrelated to growth hormone, but when we look at what's the most common cause of dwarfism, it's actually achondroplasia, which is an autosomal dominant cause of dwarfism. So they have decreased or abnormal growth in their growth plates. So chondroplasia, referring to those growth plates. On physical exam for this, for somebody who has dwarfism, less than the 3rd percentile on their normal growth charts for their well child checks, less than 2 inches of height increase per year, and then less than 4'10" as an adult. So those are our physical diagnostic criteria. Growth hormone deficiency can certainly cause this, but remember for your boards, the most common cause of dwarfism is going to be that genetic achondroplasia. Growth hormone deficiency and malnutrition can certainly cause somebody not to grow to their maximum potential. If they have a growth hormone deficiency, the lab finding that you'll have is a low insulin-like growth factor 1. Growth hormone injections can be used to treat somebody who has a lack of growth hormones, but there is no treatment for somebody with achondroplasia. Somatropin is the medication, is the name of the medication that can be given to people who have decreased levels of growth hormone. If they have malnutrition and that's the cause of their dwarfism, you want to correct that. And again, dwarfism, not so much caused by malnutrition. Really remember achondroplasia, and then if lack of growth hormone, we want to give that in the form of somatropin. The opposite of dwarfism, we have gigantism and acromegaly. On the right top picture there, that's Robert Wadlow, and he was a form of a giant, and he was back in the 1930s and 1940s, and he was in the Guinness Book of World Records for being one of the tallest humans. I think that record has probably been displaced at this point, but you can see a picture of him compared to a man of normal stature. Then on the bottom, we have an example of acromegaly. This is Andre the Giant, and he has also passed away at this point. Let's look at the differences between these two. In gigantism, they're going to be taller than their peers. You can also be tall in acromegaly, but the big difference is going to be long bone growth in gigantism, whereas it's mostly soft tissue growth in acromegaly. Other history findings, hyperhidrosis, comorbid sleep apnea because of the overgrowth of the tissues in the throat, carpal tunnel syndrome because they get increased soft tissue growth in the very finite, very static canal of that carpal tunnel, cardiomegaly because their heart has to pump so much harder to get that blood up to the brain, and then hypertension, again, kind of related to that. Their heart has to pump so much harder to get that blood further up to the brain. In gigantism, the way that you're going to distinguish this is that they are more than 2 standard deviations taller than expected. They may also have macrocephaly, large hands, feet, and face, and prognathism, where their jaw kind of sticks out on the bottom. In acromegaly, it's a lot of the same things, but they're not going to have that height. That's our differential. So macroglossia, enlarged tongue, large face, hands, feet, that prognathism, that jaw is going to stick out, and then frontal bossing, an enlarged forehead. In this is a pituitary tumor that's going to secrete growth hormone, which is going to trigger the release of insulin-like growth factor 1. Gigantism is where it happens before the physes or the growth plates close. That's why they get that long bone growth. They will also get soft tissue hypertrophy. In acromegaly, it's the stimulation of growth hormone and IGF-1, but it's after those growth plates have closed. So that's why you don't see the height on those people with acromegaly, but they still have that soft tissue hypertrophy. In the lab findings for this, we'll have an increased insulin-like growth factor 1 due to increased growth hormone production. Remember that growth hormone stimulates IGF-1. A glucose suppression test is going to be kind of our gold standard diagnostic for this, and we're going to look at this in the next slide in a little bit more detail. Normally, exogenous glucose should increase IGF-1 and suppress growth hormone, but in these patients, that growth hormone remains elevated. We'll look at this in just one moment in a little bit more detail. The brain MRI is going to show us that pituitary adenoma, so that's a definitive cause determination. We treat this with somatostatin analogs to try to inhibit that growth hormone secretion, and that's octreotide. Or we can treat this with a dopamine agonist because this will counter-regulate those growth hormone levels, and bromocriptine is an example of that. We can also use a growth hormone receptor agonist, so it blocks the receptor, and then a transphenol adenectomy where you go in and take out the pituitary gland. So let's look for a second at that glucose suppression test. Remember, this is going to be our gold standard diagnostic, definitive diagnostic for this one. So we're going to give a patient exogenous glucose. Normally, the insulin-like growth factor should go up and the growth hormone is turned down. In these patients, the insulin-like growth factor will go up, but the growth hormone will still be elevated. So this is why it's our diagnostic criteria for this. Next, we'll talk about Cushing's disease and Cushing's syndrome. This is highly tested for the boards. In Cushing's disease and Cushing's syndrome, there's so many history and physical exam findings that help to set this one apart. Let's look at our pictures first. So on the right, you see this is something called a moon face, where they get this kind of wide, round face. And then in the bottom picture, that's abdominal striae. They get these kind of stretch mark, reddish purple discolorations on the abdomen. On the history for this, weight gain, bruising, amenorrhea, those are very common ones. On the physical exam finding, moon face, we talked about that. Abdominal striae, hirsutism, they get male pattern hair on the face. Posterior and supraclavicular fat pads. This used to be called a buffalo hump. That's not very nice, so we don't call it that anymore. So posterior and supraclavicular fat pad. Acne, telangiectasia, they get these kind of spiderweb looking veins on the skin. Skin atrophy or thinning, hair thinning, and truncal obesity. The difference between Cushing's disease and Cushing's syndrome is that you remember S for S. Syndrome is due to exogenous steroids, whereas disease is due to a pituitary adenoma most commonly. There's two main causes of Cushing's disease. So a pituitary adenoma or a small cell lung cancer can cause excess ACTH. The ACTH works on the adrenal glands, or you could have an adrenal cancer itself that's producing excess cortisol. We're going to look at this in just one slide here in a minute. So excess cortisol is the key to Cushing's disease. The definitive test for this is going to be an elevated 24-hour free urine cortisol. The dexamethasone suppression test, which we'll look on the next slide, the abnormal results is that no matter what we do, they're going to have an elevated cortisol level. Serum ACTH is another lab that we'll test here. If the ACTH is elevated, we know it's coming either from that lung cancer or a pituitary tumor. Then we're going to get a chest CT or a brain MRI to try to figure out where that's coming from. If the ACTH is normal and it's only the cortisol that's elevated, we know that it has to be coming from something in the adrenal glands. So you're going to get an abdominal MRI to evaluate that. So we're going to go over that again in just one slide. Epidemiology for this, it's much more common in females than in males. Now that's true mostly for Cushing's syndrome, because a lot of the autoimmune disorders that are treated with steroids happen more in women. So that's kind of an incidental finding there. If they have Cushing's syndrome and they're getting too much steroids, you want to taper that dose down. You don't want to do an abrupt withdrawal for that, because that can trigger an adrenal crisis. Somatostatin analog will help to inhibit the ACTH secretion. Cortisol production inhibitor, so we're turning off the production of that cortisol, is ketoconazole is the drug for that. Cortisol receptor blockers, so that you're not having the effects of that cortisol, that's going to be mifepristone. And then tumor resection. If it's a tumor, we got to figure out where it is. Is it the pituitary? Is it the adrenal? Is it the lung? And then we want to take that out. We want to resect that. If they have prolonged Cushing's disease or Cushing's syndrome, this can lead to osteoporosis, immunosuppression, diabetes, and hypertension. We know that high levels of cortisol are kind of our stress hormones there. So the more stress we have, eventually the more immunocompromised we're going to be. Let's look at that test that I mentioned. So let's go back to that dexamethasone suppression test. We're going to give the patient an exogenous steroid. The normal result should be that that cortisol turns down because we're giving them an external steroid. In Cushing's disease, the cortisol will remain elevated. Remember, that's diagnostic for this, is elevated cortisol. Then we're going to look at the ACTH levels, and that's going to be our lab finding for that. If the ACTH is high, it could be coming from a pituitary tumor. And in that case, we want to get a brain MRI. It could also be coming from a lung tumor. And in that case, we would get that chest CT. So if you're not sure, you can order both. Let's say that the ACTH is normal. So it's not something that's coming from higher up. It's something that's actually happening at the adrenal glands that's producing that cortisol at an abnormally high level. So then we're going to think about the adrenal tumor and we're going to get an abdominal CT. So this kind of helps you to separate out, is it cortisol? Is it ACTH? What's regulating this? Next, we're going to talk about ADH diseases. So on the left here, we have something called diabetes insipidus. And on the right, we have SIADH, or the syndrome of inappropriate ADH secretion. So let's start over here on the left and kind of, what are we looking at? So we've got the pituitary gland on the top right there. We've got our kidneys, we've got our bloodstream, that's going to be simulated by that red area. Then we've got our bladder, and that's going to simulate what our urine production is. So in diabetes insipidus, we don't have enough ADH. ADH is an anti-diuretic hormone. It's what tells us to conserve water. So if we don't have enough of that, we're losing all of this water out into the urine. So you get this very copious amounts of urine that are not dilute at all. Then you lose all that water, so the bloodstream becomes more concentrated, and that's going to cause a hypernatremia. In SIADH, it's the opposite. So you have too much ADH. So you're conserving too much water. So all of that water will go into the bloodstream and dilute the bloodstream. So you get a hyponatremia, and then you'll get a very small amount of concentrated urine. We'll go in those in specifics in just that slide here, but kind of let this remind you. So remember, diabetes insipidus, we don't have enough. SIADH, we have too much. So let's start with diabetes insipidus. Remember, that's the one on the left. So polyuria, nocturia, polydipsia, they're making lots and lots and lots of urine. And what happens when we lose a lot of water, we get dehydrated. So physical exam findings are non-specific, but just for dehydration. So decreased skin turgor, dry mucous membranes. This is a deficiency in ADH that causes water loss into the urine, causes lots of dilute urine, and then plasma hypernatremia. There's two causes of this. Central is at the pituitary gland. So it's a decreased ADH secretion by the pituitary gland. What can cause this can be completely idiopathic. We don't know, but it can also be related to brain trauma, brain surgery, or a brain tumor. Nephrogenic, we know it's something going on at the kidneys. So it's renal resistance to the ADH. So things that could cause this would be chronic kidney disease, renal disease, and lithium, which is a medication that's used for a lot of psychological disorders, not so commonly now, but it is still used. Diagnostic criteria of diabetes insipidus: more than 3 liters of very dilute urine within 24 hours and a serum hypernatremia, so over 145. We're going to look at this on the next slide here, but this is called a water deprivation test. What if your patient's just making a lot of urine because they're drinking a lot? The water deprivation test helps us to sort that out. So we're going to deprive them of water. And if they don't have this, their urine should now become concentrated because they don't have so much water in their system. If the urine is still dilute, then we're going to give them ADH. If it's central diabetes insipidus, that urine will correct out and it'll now become concentrated. If it's nephrogenic, nothing's going to happen because the problem is not that you don't have enough ADH, it's that the kidney's not responding to it. Treatment for this, central diabetes insipidus, is give them an ADH analog. So desmopressin or vasopressin are synthetic forms of that. If it's nephrogenic DI, we actually give them a diuretic, which seems counterintuitive, but it paradoxically slows the GFR. And so that becomes more concentrated. So hydrochlorothiazide would be an example of that. In SIADH, typically they're asymptomatic. If it's very severe, that's due to the fact that they have hyponatremia, so malaise, headache, or cramps. Altered mental status, hyporeflexia, again, that's related to the sodium concentration in the bloodstream. With SIADH, we're producing too much. So excess ADH causes excessive water resorption. So we get this small amount of ultra concentrated urine and plasma hyponatremia because all of that water is being absorbed into there. Things that cause SIADH: central nervous system disorders, things like multiple sclerosis, head trauma, CVA, or stroke. Cancer, some of the cancers can secrete ADH, and the most common one of that is going to be a small cell lung cancer. Lung disease, hypercapnia, so high levels of carbon dioxide, reduce renal blood flow, so things like pneumonia and COPD. And then drugs that can induce this, SSRIs, these are used for antidepressants, tricyclic antidepressants, anticonvulsant medications, some of the analgesics, and then chemotherapy medications. Our diagnostic criteria for this one, it's a small amount of ultra concentrated urine and a serum hyponatremia, so very unconcentrated bloodstream. So that's going to be less than 135. Retained water is going to dilute that serum sodium. And I'm going to show you this again in just another slide here to kind of hit this point home. A vasopressin receptor antagonist come in and they block those receptors, so they're not responding to that. Diuretics can also help to treat this. They help to produce more urine. And then diabetes insipidus inducers, lithium, remember, causes diabetes insipidus. So if we have SIADH and we know something causes diabetes insipidus, now this kind of brings you back to normal. If they're very, very severe and they are symptomatic from this, you can give them hypertonic saline to try to balance out that sodium in the bloodstream. So let's look at this in another way here. Let's talk about that water deprivation test for diabetes insipidus. Remember, this is how we're sorting out, are they just taking in too much water or do they actually have diabetes insipidus? So we're going to deprive them of water. Normally that urine should now become concentrated, but in patients with diabetes insipidus, they'll continue to have a dilute urine. Then we're going to give them ADH and see what happens. In central DI, where they don't have any ADH production, now we're replacing what they don't have. Now our urine becomes concentrated. In nephrogenic, it doesn't matter if we give them ADH because the kidneys aren't responding properly to it. So even if you give them ADH, if it's nephrogenic, they'll still have a dilute urine. That's why that water deprivation test helps us to sort that out. This is another way that I like to explain the diabetes and the SIADH. Let's kind of set this up here. So for example, let's say, just for simplicity, we have a normal plasma salt to water concentration of 1:1. Okay. In diabetes insipidus, remember that we're getting rid of all of that water. So the salt concentration never changes, but the water concentration does. So if you were to drink out of that glass, it would taste a lot more salty just because the water component of that is gone. That's why you get the serum hypernatremia. In SIADH, again, the salt concentration does not change, but the water concentration does, and you're resorbing more and more water. So if you were to drink out of that last glass, it would taste a lot less salty than the middle glass because you retained more water. You're diluting that salt with the more water. Hopefully that kind of helps to hit that point home. Next, we're going to talk about our thyroid and parathyroid conditions. Reminder for those before we get started, we have T3, T4, that's released by thyroid stimulating hormone that targets the brain, the lungs, and the heart. It affects our basal metabolic rate, thermoregulation, heart and respiratory rate, and our neural development. This will be inhibited by increased levels of T3 and T4. Then we have calcitonin, and if you can remember COB, calcitonin stimulates osteoblasts. So if we have high level of calcium, hypercalcemia, it will stimulate the osteoblast to incorporate that calcium into the bone. It works at both the bone and the kidney. So again, those osteoblasts, they build bone and to decrease the serum calcium with the kidney. Hypocalcemia and parathyroid hormone will turn off calcitonin. Parathyroid, if you can remember, POC, it stimulates osteoclast. So hypocalcemia will trigger the body to have osteoclast chew the calcium out of the bone and deposit it back into the bloodstream. So this works at the bone, the kidney, and the intestines to increase the serum calcium. If we have too much calcium or we have calcitonin, that will turn that off. So remember, POC and COB work kind of opposite of each other. So here's our thyroid function. Remember, T3 and T4 are going to regulate the metabolism, and then calcitonin decreases serum calcium. So here we have our thyroid. We've got our T3, T4. That's what stimulates our metabolism. Our calcitonin is produced by the parafollicular C cells, and they're going to cause a decreased renal calcium uptake, and they're going to stimulate the osteoblast to incorporate that calcium into forming bones. So they build the bones. They take the calcium out of the bloodstream and they put it into the bones. For the parathyroid, remember, parathyroid is going to increase our calcium. Parathyroid are 4 little glands that live on each of the kind of lobes of the thyroid gland there. So this is one of the functions. Parathyroid stimulates vitamin D to increase the calcium intestinal uptake. So we're putting that back into our bloodstream now. Parathyroid also works at the level of the kidney to increase the renal calcium uptake. And then remember, POC, it stimulates the osteoclast to chew the calcium out of the bone and deposit it back into the bloodstream. So intestine, renal, and bone is where that acts at. When we're talking about calcium homeostasis, remember that I said that parathyroid and calcitonin kind of work opposite of each other. So remember POC. Parathyroid stimulates the osteoclast to elevate the serum calcium, and COB, calcitonin, stimulates the osteoblast to decrease the serum calcium. So let's start here. So let's say that we're kind of high, right? Calcitonin is going to work to decrease our renal uptake and put the calcium into the bone. So the calcitonin will help to bring our calcium levels back down to normal. Let's say that we're too low. That parathyroid, remember, is going to stimulate the renal uptake, the intestinal uptake, and the osteoclast to release that calcium back into the bloodstream. So this is how they're working opposite of each other to keep that calcium homeostasis. Our thyroid lab diagnosis, you'll probably have a board question on this. This is where it gets a little hairy. So you always want to start by looking at the T4. If the T4 is low, we know it's some kind of hypothyroidism. If the T4 is low and the TSH is low, we know that it's a problem coming from the pituitary gland, because the TSH should be elevated if the T4 is low. So we would call that a secondary hypothyroidism. If the T4 is low, but the TSH is elevated, the pituitary is doing its job by releasing that TSH, but the T4 is still low. So we know this has to be a problem at the gland. And remember, we said if it's at the gland, it's a primary form of dysfunction. So a T4 low and a TSH low, it's a problem at the pituitary. It's a secondary hypothyroidism. If the T4 is low and the TSH is elevated, it's going to be a problem at the gland. So your primary hypothyroidism. Right, next, if our T4 is high, we know it has to be some kind of hyperthyroidism. If the T4 is high and the TSH is low, the pituitary is doing its job. So that's a primary hyperthyroidism. That's a dysfunction at the gland itself. If the T4 is high and the TSH is high, that means the pituitary is not responding properly by turning itself down. So that's going to be a secondary hyperthyroidism. Let's talk about hyperthyroidism. So Graves' disease or toxic nodular goiter. The history for this, the way that I think about hyperthyroidism is I think about a chihuahua. They're always kind of hyper and revved up. So think chihuahua for hyperthyroidism. Weight loss, palpitations, anxiety, they're all revved up temperature-wise, so they get this heat intolerance. Their gut is revved up, so they get diarrhea. Dysmenorrhea, hyperhidrosis, those are less common as far as the physical exam findings that you'll be tested on. They may also get a mass effect. If their thyroid is enlarged, it can push on their esophagus and on their trachea. So dysphagia, hoarseness, dyspnea. Physical exam findings for this. Remember, they're revved up, they're hyper. So fever, tachycardia, exophthalmos. This is the top picture here. The fat pad behind the eyeball becomes enlarged, so they get this kind of bulging of the eyes. This is very specific to hyperthyroidism. Tremor, hypertension, remember everything's revved up. Pretibial myxedema. This is a bilateral, non-pitting kind of yellowish red shin plaques. And this is due to an increase in hyaluronic acid that's associated with this disease. If they have a diffuse goiter or enlarged thyroid, we call this Graves. If it's a nodular, we call it toxic nodular goiter. Graves is an autoimmune disorder where the body attacks the thyroid tissue. Toxic nodular goiter is due to an iodine deficiency. So iodine is required for T3 and T4 production. If you don't have enough, the body develops these little hyper-functioning nodules to increase the production of T3, T4. Medications that also increase iodine availability and T3, T4 production, some of the weight loss thyroid medications can do this. Amiodarone, this is used as an antiarrhythmic. Amiodarone, IOD, has iodine in it. And then iodine itself is you can buy something, over the counter capsules with iodine. Graves is more common in females age 20 to 40. It's an autoimmune disorder, and that's typically when we see these. And then females over 40 is going to be our more common demographic for the toxic nodular goiter. Labs for this, we're going to have a serum increase T3, T4, and a decreased TSH, because remember, it's not the problem with the pituitary, it's a problem with the thyroid gland itself. They will also have an increase in radioactive labeled iodine uptake, And then you do that nuclear thyroid scan. So you get that radioactive iodine uptake and do a nuclear scan. In Graves' disease, they will have diffuse iodine uptake. In toxic nodular goiter, they'll have these small areas of focal uptake of that. We want to treat these patients with an anti-thyroid medication. So PTU, and PTU, it can be safer in pregnancy, but there are some kind of caveats there for which trimester it's safer in. But if you're at the boards and you're trying to pick which one is safer in the pregnancy, I remember PTU for pregnancy. And then MMI is also a medication that we can use to turn that thyroid down. To treat some of the symptoms, those anxiety, palpitations, tachycardia, we can use a beta blocker, so propranolol. We can also treat this with steroids if it's Graves' disease, because that's an autoimmune disorder. Remember, steroids kind of turn down the immune system. If it is very symptomatic and it's not responding to those medications, we can do a radioactive iodine ablation where it kills off the thyroid tissues, or we can do a thyroidectomy where we go in and actually take that out. But remember, you have to replace those hormones for those patients with a levothyroxine or other medications like that to replace the thyroid gland. Hypothyroidism. There's 3 diseases that belong in this category, and I'm going to talk about them separately, but I want you to learn them together. So Hashimoto's thyroiditis, Dequervain's thyroiditis, and endemic goiter. I want you to think about a sloth for hypothyroidism. So we thought about a chihuahua for our hyperthyroidism. Hypo, everything's slowed down. So kind of think about a sloth. Constipation, the gut is slowed down. Depression, fatigue, weight gain, the thermostat is turned down, so they get cold sensitivity. Menorrhagia, carpal tunnel, they get this kind of widespread edema that can cause compression of the median nerve. And then throat fullness. If you look at that top picture there, that's endemic goiter, you can see why they may have a feeling of throat fullness. On physical exam, dry skin, coarse brittle hair, hair loss, periorbital puffiness, bradycardia, the heart is slowed, pitting edema, hyporeflexia, hoarseness if they have that mass effect. And then in infants, look at this bottom picture here. This is an example of congenital hypothyroidism. They get macroglossia, enlarged tongue, and an umbilical hernia. So causes of hypothyroidism, well, this makes sense. If you take it out, you develop a hypothyroidism. It can be congenital, as we saw in that baby there. It can be postpartum in that Sheehan syndrome that we talked about on our second objective slide. And then medications like lithium can knock out the thyroid gland as well. In Hashimoto's, this is going to be the most common type. This is painless. It's an autoimmune destruction of the thyroid gland, and they will have anti-TPO, thyroid peroxidase antibodies. What happens here is that the body goes in and kills off the little thyroid cells. And so at first you develop a hyperthyroid state. As it kills off the cell, pew, 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 it releases the T3, T4. So they go into a hyperthyroid state and then boom, followed by a hypothyroid state after those cells are killed off. In Dequervain's, the key point about this one is that it's a painful thyroiditis. They actually have a painful thyroid. This is associated with some kind of upper respiratory infection that was recently in their history, and they will have an elevated sedimentation rate, so an elevated ESR in this. This usually starts as a hyperthyroid state in that inflammatory process, and then it goes into a hypothyroid state. In endemic goiter, which is the top picture there, this is non-toxic, so they don't have these hyperfunctioning nodules, and it's diffuse. This is due to a deficiency in iodine, which is why we call it endemic. Certain areas are deficient in iodine. In the United States, we don't really see this anymore because we have iodine supplementation in our favorite food, which is salt. In this, the body tries to increase the T3, T4 production by enlarging the thyroid. And this is much more common in Asian and African countries where they don't supplement the iodine and the salt. The most likely person to get Hashimoto's thyroiditis is going to be females, and they're usually going to be younger, but overall in these, females over the age of 60s, and then infants if it's a congenital form. Hypothyroidism, the T3, T4 is going to be low, and the TSH is going to be elevated because the pituitary is trying to get the release of it, but it stays low. Ultrasound of the thyroid, and then a fine needle aspiration to try to figure out what could be possibly the cause of this. Remember also that anti-TPO antibodies if you're looking for Hashimoto's. So we treat this, we can use levothyroxine, which is also called Synthroid, and that's a synthetic form of T4. Cytomel is a synthetic form of T3. And then you can use desiccated thyroid, which is a combination of T3, T4. That's called Armour thyroid if you're looking for the brand name of that. Treatment of choice for Decker veins is going to be anti-inflammatory medications because this is an inflammatory type of condition. And then if we have endemic goiter, remember that's a response to low iodine. So if we supplement the iodine, that will get better. Next, let's talk about thyroid storm and myxedema coma. Thyroid storm, just think about this as a severe hyperthyroid state. Myxedema coma is a severe hypothyroid state. So let's start with thyroid storm, also called severe thyrotoxicosis. Vomiting, diarrhea, everything's hyper. So hyperthermia over 104, hyperhidrosis, hypertension, tachycardia, seizures. This is an emergent hyperthyroid state. And this can be due to thyroid surgery, where they mess with the thyroid, you get this massive release of T3, T4, thyroid trauma. Sometimes you can see this if somebody has been strangled, they can get this release of T3, T4 because you're compressing that area. Thyroid medication overdose. If somebody's trying to take this as a weight loss mechanism and they take too much, this can cause a thyroid storm. This is very rare typically, and it's usually in elderly females for both of these disorders here. So if you see a younger person with this, try to think about what could they have been taking for perhaps a weight loss medication where they overdosed on this. Labs for this is extremely elevated T3, T4, and they may have EKG findings, something like atrial fibrillation. Treat them. We want to get everything low. So fluids, ice packs, acetaminophen to treat the fever, beta blocker to slow down the heart rate, anti-thyroid medications. So there's that PTU and MMI, steroid medications, and this will lead to a 90% mortality if untreated. So this is an inpatient admit for this patient. Myxedema coma, there's not much history because they're in a coma typically. This is a very severe hypothyroid state. So hypothermia, hyporeflexia, hypotension, hypoventilation, bradycardia, facial swelling. So this is an emergent hypothyroid state, and it's usually due to some kind of stressor in an already hypothyroid patient. So if they get some kind of infection, they have a stroke, they have a myocardial infarction, they forgot to take their medication, so a thyroid medication withdrawal. This is rare, and this is elderly females. This is going to be a low state. So hyponatremia, hypoglycemia, decreased T3, T4. And then on EKG, there's a specific finding. This may be a board question for you. The J wave of Osborne. This is non-specific to myxedema coma, but it's associated with somebody who has severe hypothermia. For this patient, we want to bring everything back up. So fluids, passive rewarming, ventilation, IV T3, T4, and steroids. This one has a 40% mortality if untreated. Next, let's talk about thyroid cancer. In thyroid cancer, you can have hyper or hypothyroid symptoms or no symptoms at all. Sometimes it's asymptomatic. Sometimes you can get B symptoms, which are secondary symptoms just to cancer in itself. So fever and night sweats are common. If the cancer becomes large enough, you can have a mass effect where it pushes on the throat. So dysphagia, hoarseness. On physical exam, a thyroid nodule is how they will set up the question for you. So-and-so presents with a thyroid nodule. Etiology of this is really important. And the way that I tell people to remember this is pay for me always. Isn't that nice if somebody pays for me always? This is in order of the best prognosis to the worst prognosis. So let's start with papillary. Fortunately, papillary makes up 75% of thyroid cancer. And the good news is it's the best prognosis. So it's a very slow growing type of cancer. It's non-metastatic. Typically, it's radiation induced. So they had some kind of history of radiation to the throat. Age 30 to 40, they tend to be pretty healthy at that age, and it's the best prognosis. Then we go down to the next step, which is follicular. That makes up about 15% of thyroid cancer, and these are Hürthle cells. That's going to be the board question. If they ask you what thyroid nodule or thyroid cancer is associated with Hürthle cells, that's going to be follicular. Medullary makes up 10%. This can either be sporadic, which occurs in the elderly, or familial, associated with multiple endocrine neoplasia type 2, which we'll talk about at the end of this lecture. This is made up of the C, or the parafollicular cells. And so don't get confused when you think follicular cancer, parafollicular cells. Remember, follicular is Herthel, medullary is parafollicular cells. This one is also associated with the hypersecretion of calcitonin. And then finally, anaplastic. Fortunately, this only makes up 3%, but this is a very aggressive, resistant, and metastatic type of cancer. There's 4 different types: giant cell, spindle cell, mixed cell, and small cell. This is usually in the elderly patient, and it has the worst prognosis, so 6 to 8 months. Thyroid cancer has a higher incidence in females and a higher mortality in males. That is because males usually wait longer to go get it checked out, and at that point, it's more problematic. Normally, TSH, T3, T4 will be normal. There's not any findings with this. Sometimes it can be elevated, sometimes it's not. Remember that calcitonin will be increased in medullary only. That's a good board question there. What is the first diagnostic criteria for a nodule of the thyroid? Is going to be fine needle aspiration. That's going to be the answer to your question. What is the most definitive test of a thyroid nodule? Is going to be fine needle aspiration, because it gives us a cytology. We know what that cell is. We can also do an ultrasound to image this. If it's malignant or worrisome, cancerous, it's over 1 centimeter generally. It's usually dark, hypoechoic. It's irregular. It has calcifications, or it's hypervascular. Remember that cancer bleeds a lot because that's how it grows. It has a good blood supply. Radioactive thyroid scan, if it's cold, meaning the nodule does not light up, it's usually cancer, because those are non-normally functioning cells. So it's cold, it's not hot, it's not functioning. Treatment for this: thyroidectomy, radioactive iodine ablation, depending on what type cancer it is, and then chemotherapy if it's a metastatic type of cancer. Next, we're going to talk about hypocalcemia, so low levels of calcium. In this, the history exam for this, depending on how bad it is: oral and extremity paresthesias, numbness and tingling around the mouth, in the fingertips, in the toes, seizures, muscle cramps. On physical exam, these are the ones you're going to be tested on. You have the Chopstick sign. This is where you tap over the facial nerve and they'll get a facial twitch on the same side. The way that I remember this, and I don't know if it'll help you, is I remember I eat with chopsticks. That's up near my face. So chopsticks is tapping on the facial nerve. Trousseau sign is where you inflate a blood pressure cuff, and they'll actually get thumb adduction and metacarpal flexion from that. If the calcium is very low, you can get a spastic paraplegia. You can get tetany, or tightness of the muscles. They can have poor dentition, because we know calcium helps to make up the composition of our teeth. Brittle hair, brittle nails. Most common causes of hypocalcemia are hypoparathyroidism, hypoalbuminemia, and people who have liver or renal disease, malnutrition, or sepsis can get hypoalbuminemia. Hypomagnesemia, so your magnesium is low. That's typically due to malabsorption. They're not getting enough in their diet. Vitamin D deficiency makes the parathyroid ineffective, so you can develop the hypocalcemia because of that. Some of the osteoporosis medications deposit calcium in the bone, and they can cause a hypocalcemia. So an example of that is denosumab or Prolia. You can also have a decreased absorption of calcium from the diet. So if they had a pancreatectomy or they had a small bowel resection, then you may have a decreased absorption. Or something called hypercalciuria, where they actually spill out calcium into the urine because they have a defective receptor in the kidney. By definition, hypocalcemia is a serum calcium of less than 8.5 or an ionized calcium of less than 4.0. Remember that ionized calcium measures the free calcium. The labs that we should order in the workup of this patient are a parathyroid, a magnesium, and a vitamin D, remember, because those are the causes of this. On X-ray, we may also see that they have demineralization, and that will be commented as osteopenia. And then on EKG, depending on how severe this is, you can get a prolonged QT segment. Treatment for hypocalcemia is to replace it. So you can use calcium carbonate, calcium citrate. If the vitamin D is low, you would use cholecalciferol. D3 is more effective at raising the blood levels of vitamin D than D2. Magnesium, you would correct that if that is low. So that is hypocalcemia. And the biggest takeaway points for this one are Chopsticks and Trousseaus. That's typically going to be your board question on those. Hypercalcemia, we have too much calcium in the bloodstream. So this will be a calcium over 10.5 or an ionized over 5.2. Stones, bones, abdominal groans, and psychic moans is kind of the way to remember this one. So stones, nephrolithiasis, they get a buildup of calcium in the bloodstream, in the urine, and so they get kidney stones. Bone pain, constipation, and depression. High levels of calcium can cause a serotonin and dopamine dysfunction. So they actually get depression from this. They can also get comorbid peptic ulcers because calcium will increase the gastric acid production, causing more ulcerations. It can also cause acute pancreatitis because it blocks the secretions of the pancreas, and then you get this backup of pancreatic enzymes. If it's very severe, you can get an arrhythmia, hypotension, hypotonia, confusion, and paresis. The most common cause by far of hypercalcemia is going to be oversupplementation. Take a look at all of your patient medications, have them bring their bag in, dump them all out on the table, and figure out where you're getting calcium from, because they usually get it from a multivitamin, from their diet, plus extra calcium supplementation that they're taking. So rule that out first. Hyperparathyroidism is the most common internal etiology, so not a supplement that they're taking. Some cancers can also secrete parathyroid hormone-related peptide, and this can be things like multiple myeloma, breast cancers, lung cancers, renal, esophageal, cervical, endometrial, ovarian, and lymphomas. So they can cause this parathyroid-like syndrome where the body starts chewing up the calcium out of the bones and releasing it into the bloodstream. Thiazide diuretics can also decrease the calcium excretion, and so that can make high levels there. Also, if you have something called Paget's disease of the bone, that increases bone remodeling, and we'll talk about that in a minute. Serum calcium, a total calcium over 10.5, like I said, and ionized calcium of over 5.2. The labs that we should order in the workup of this patient are going to be the parathyroid levels, urine calcium, vitamin D, and then parathyroid hormone related peptide. And that's kind of a specialty lab. As a primary care, you're probably not going to be ordering that one, but certainly a parathyroid and a vitamin D would be appropriate. You also want to rule out any cancers if you have suspicion of that. So if they haven't gotten their recommended screening, let's say they're having B symptoms, night sweats, weight loss, you would be thinking more cancer in that situation. So a thoracic and abdominal CT would be reasonable, and a mammogram. On EKG, if you have too much calcium, that can actually shorten that QT segment. First thing we want to do is adjust their nutritional supplement or their dietary intake to less than 1,200 milligrams a day. This is definitely where you want to get your endocrinologist involved. If it's hyperparathyroidism, oncology, if it's cancer related, you want to supplement their vitamin D at a very low level. So only if it's low, because if you supplement a high level of vitamin D and they already have a high level of calcium, you'll make their calcium go even higher. Calcitonin is a medication that can lower the calcium. Remember, COB, it stimulates the osteoblast to drop that calcium level. Calcium mimetics, so cinacalcet, will actually suppress the parathyroid gland if that's the issue. Bisphosphonates are medication that we use to treat osteoporosis, and they suppress the osteoclast from chewing up the bone. And then a loop diuretic helps us to increase the calcium excretion. You don't want to give them a thiazide, because if you give them a thiazide, remember that will increase the levels of calcium. Hypoparathyroidism and hyperparathyroidism. Much, much more common for the hyperparathyroidism than the hypo. In the hypoparathyroidism, it's going to be the same history as hypocalcemia and the same physical exam as hypocalcemia, depending on how severe it is. The most common cause of hypoparathyroidism is they've taken out the entire thyroid gland and they did not replant the parathyroid glands. Types of face and neck radiation can kill the parathyroid glands. Low levels of magnesium in the blood can cause a hypoparathyroidism. Autoimmune disorders, congenital hypoplasia, amyloidosis causes scar tissue infiltrates in the gland. Metal overload, diseases like hemochromatosis, Wilson's disease, not very common, but things that you could be thinking about. Diagnostic for this is going to be a decreased PTH and a decreased calcium, because remember, parathyroid elevates the calcium. You will also have an elevated phosphorus. Parathyroid promotes the excretion of phosphorus in the urine. So if you don't have enough of it, then you're holding on to that. You also want to look at your magnesium levels, because remember, low levels of magnesium can cause a hypoparathyroidism. We want to treat this with replacement of calcium levels, vitamin D supplementation, magnesium supplementation if it's needed, and then synthetic parathyroid hormones. So recombinant human PTH is what that's called. In hyperparathyroidism, much more common. So same findings as hypercalcemia. They will also develop osteoporosis at an early age. Same physical exam findings as hypercalcemia. Primary hyperparathyroidism. Remember, primary is at the level of the gland. So it's a parathyroid adenoma, or it could be a carcinoma, very rarely, but associated with multiple endocrine neoplasia syndrome type 1. Secondary hyperparathyroidism is very common from either people in renal failure or vitamin D deficiency. And when you correct the vitamin D deficiency, the parathyroidism corrects as well. Diagnostic for this is elevated PTH, elevated ionized calcium, decreased phosphorus. Vitamin D is decreased if it's secondary. You would do a parathyroid scan, so an ultrasound or a nuclear CT scan if you're thinking that it's primary. So if your calcium's elevated and your parathyroid is elevated, you would do this scan. You also want to monitor them for osteoporosis, so getting a DEXA scan or a bone density scan. If it's primary, you've gotten your labs, you've gotten your imaging, and you've confirmed that, you can do an excision if they're a good surgical candidate, or a calcium mimetic. So cinacalcet actually lowers that parathyroid hormone using medication. If it's secondary, most commonly by vitamin D deficiency, you're going to increase that vitamin D and the parathyroid should settle down. Bisphosphonates can also be helpful for people who are in renal failure. So these are the medications that end in dronate. These suppress the osteoclast, so therefore you're not chewing that calcium up and releasing it into the bloodstream. Pediatric vitamin D deficiency is also called rickets. This is not very common in the United States because we supplement with vitamin D. This is more common in third world countries where you have prolonged breastfeeding. If you have a lack of sunlight for that patient, remember we can absorb vitamin D from sunlight. Physical exam findings, and these are pretty specific and good board questions here. So wide, long bone ends, frontal bossing, enlargement of the forehead, bowed legs, you can see in that picture there, the bowing of the femur, knocked knees, the rachitic rosary, where they get this kind of, it looks like the rosary, the Catholic necklace that they wear. They get these kind of beaded areas on the costochondral junctions. A sternum pigeon breast deformity is called pectus carinatum. Vitamin D deficiency in childhood prevents calcium and phosphorus from being deposited into the bones, and so their growth plates never mineralized. They usually develop a secondary hyperparathyroidism because they have a low vitamin D. So it's kind of two insults here. One is the fact that they never incorporate the calcium and the phosphorus into the bone, and then two is that they have increased remodeling from the secondary hyperparathyroidism. On labs for this, we'll see a decreased calcium, decreased vitamin D, increased parathyroid, because remember that's secondary to the low vitamin D. X-ray findings, and these are in the pictures here. So we have no physeal scar, that growth plate never mineralized. Demineralization of the bones, they look kind of like ghosty bones. They're kind of lightish gray in coloration instead of bright white. And then bowed long bones, as you can see in that top picture there. We treat this with cholecalciferol, which is vitamin D. It's more of an animal-based vitamin D, and that is much more effective than ergocalciferol, which is a plant-based. If we have vitamin D deficiencies in adults, we call that osteomalacia. So this is not osteoporosis, which is brittle bones. This is softening of the bones. They may have a history of easy fracturing. Bone and joint pain are much less common complaints. Waddling gait, bony tenderness, depending on the severity of this. This is failure to mineralize of the bones in adulthood, which causes those bones to be soft and more likely to fracture with even minimal trauma. This is due to inadequacies in vitamin D consumption. So inadequate sunlight, a small bowel reception where they're not absorbing it as well, celiac sprue, cystic fibrosis, and then some anti-epileptic medications. Secondary hyperparathyroidism also is associated with this one, just like it is in rickets. On labs, very similar. Decreased calcium and vitamin D, increased parathyroid. On X-ray, they have that demineralization, kind of the ghosty bones looking very, very kind of grayish, long bone deformities, and then pseudo fractures, little tiny kind of hairline fractures throughout the skeleton because these bones are soft and they cannot have a lot of stress to them. They don't have good tensile strength to be able to absorb those regular body movements. Treatment for this is we want to supplement that vitamin D. Again, cholecalciferol is a little bit more effective than ergocalciferol. You do need to know those chemical names, cholecalciferol, ergocalciferol, because on the boards or on your exam, they're probably not going to give you vitamin D3 or vitamin D2. Next, we're going to talk about osteoporosis and osteopenia. This is very near and dear to my heart. I am a certified fracture liaison, and I'm a program director for an osteoporosis clinic in Charleston, South Carolina. So this is one that I absolutely find fascinating. And osteoporosis and osteopenia, this is thinning of the bones that causes brittle bones. History and things that make people more likely to get this. So a fragility fracture of the hip, the spine, or the wrist from a fall from standing height, we call those fragility fractures that should not fracture the bone. Women who are postmenopausal or they've had their ovaries removed. Smokers are 7 times more likely to fracture. People who have more than 3 alcoholic drinks a day. People who are sedentary, they don't exercise, so they're not stressing their bones to promote growth. People have poor dietary intake of calcium and vitamin D, and people who have chronic steroid use. Steroid use turns on the pathway to make fat cells and turns off the pathway to make bone cells. So we know there's a huge correlation with chronic steroid use and osteoporosis. Physical exam, there's not a lot of very specific findings for this. They may have a loss of height. They may have a low BMI. We know that osteoporosis is much more common in very thin women. And then kyphosis, if they've had a lot of compression fractures, they get that kind of hunched over posture of the spine. Etiology for this is decrease in estrogen or decrease in testosterone, but much more commonly decreased estrogen. Postmenopausal, that kind of takes a nosedive in the estrogen. You can also have this secondary to hyperparathyroidism, because remember, that's chewing up the bones. It can also be due to vitamin D deficiency because that acts as a taxi cab to take the calcium out of the bloodstream and puts it into the bone. Calcium depletion, if they're a smoker, they have a poor diet, they're consuming too much alcohol. If they have decreased osteocyte formation, which we see in diabetics and people who use steroids. And then hypocalcemia, either from their diet, if they have low magnesium, that can also cause this, renal disease, liver disease, or malabsorption, disuse atrophy. People who are very sedentary, they are not stressing their bones. Every time you stress the bone, you put down layers and layers of bone called lamella. And 150 minutes a week, we see a huge difference in the quality of the bone. And then multiple myeloma is a very rare secondary cause of osteoporosis that causes punched out lesions in the bone and makes them appear as thinner and causes more likely to have atraumatic fractures. Our demographics for this are Caucasian and Asian women have naturally thinner bone structure than Hispanic or African American because of the vitamin D absorption through the skin. Females over the age of 50, they're getting into that postmenopausal state, and people with rheumatoid arthritis, it's a chronic inflammatory condition, and they're more likely to be on steroids. Our diagnostic definitive criteria for this is a DEXA scan. This should be done for all women over the age of 50 with risk factors like smoking or a parent had a hip fracture, all women over the age of 65, and all males over the age of 70. The T-score of negative 2.5 or less is diagnostic for osteoporosis. -1 to -2.4 is diagnostic for osteopenia. In patients who have not had a fragility fracture and whose T-scores are better than -2.5, we do something called a FRAX score. You'll either see this on the bone density scan, or you can go to the University of Sheffield website and they'll give you a FRAX score calculator. This helps us to risk stratify patients that don't fall into the criteria of fracture or a T-score of less than -2.5. If they have an overall likelihood of having a fracture in the next 10 years of over 20% or over 3% risk in the hip, that in itself is diagnostic for osteoporosis. If they've had a fragility fracture, so a fracture of the hip, fracture of the wrist from a standing height, or 2 fractures in the spine, compression fractures, that is also diagnostic for osteoporosis. In the workup of this patient, you should be looking at a CMP to look at our calcium levels, liver function, renal function, and alkaline phosphatase is a marker of bone turnover. Magnesium is also important. Vitamin D and parathyroid, that's important in your initial workup of these patients. Treatment for these patients is to make sure that they're getting adequate vitamin D. Most people need about 1,000 to 2,000 IUs of vitamin D3 every day. Magnesium levels, calcium supplementation. You do get credit for your dietary intake of calcium, and a lot of people over supplement because they don't think about their dietary intake. So you want to look at that kind of holistically. There are estrogen, hormone replacement therapy has been shown to cause a decreased risk in fracture. We also have our selective estrogen receptor modulators like a Vista. Anti-resorptive medications like bisphosphonates, they all end in dronate. So alendronate, abandronate, zoledronic acid, osteoclastic inhibitors, denosumab or Prolia. Make sure that you understand that once you start a patient on Prolia, they must stay on it forever. It does not have the 5-year recommended course of therapy like your bisphosphonates. If they are very severely osteoporotic, you should refer them to either endocrinology or a fracture liaison service because they would benefit from an anabolic medication to quickly repave the road, as we say. So Forteo, teriparatide, Tymlos, abaloparatide, or Avinity, romosozumab are very good medications to quickly lay down new bone. Paget's disease of the bone, this is very rare. We typically see this in people over the age of 65. In Paget's disease of the bone, you get this overactivity of the osteoclast. So you get this massive skeletal remodeling. Typically, the pelvis, the tibia, the femur, the lumbar spine, and the skull are the most common places that we see this. This can either be genetic or it can be triggered by a viral infection, things like measles, rubella, and RSV. In patients with Paget's disease, they will have bone pain because they're chronically remodeling their bones. They may be deaf because those little tiny ossicles in the ear become remodeled and they become non-functional. Atraumatic fractures or fractures from minimal trauma because that bone quality is not normal. It doesn't have that good tensile strength, and so it can't withstand normal movements. Diagnostic criteria for these is going to be an increased urinary hydroxyproline and serum alkaline phosphatase. These are the byproducts of bone breakdown, and they'll be elevated. On X-ray, you may see biconcave vertebra, lytic lesions. You can see on this picture here, the top one is probably a CT scan, looks like a CT scan, and you can see the remodeling of that vertebra. And then you see the bottom one here, and that whole pelvis to the right is just absolutely abnormal. So a whole body bone scan will show us the areas where they are having remodeling. Treatment for this is the bisphosphonate group of medications, so alendronate, risindronate, because they suppress the osteoclast, and this is a disease of overactive osteoclast, so that's why that's the treatment for that. That gets us to the end of the first part here. If you're interested in learning more, you can certainly purchase the rest of this review and you'll get the full PDF of all of the slides. If you're interested in taking a practice test on this as well, that's that second option down, and there are links in the description portion of this video. You can also visit papods.weebly.com, and I'll show you what these look like. So clinical pearls are designed to be a matching exercise where you can select from a drop-down menu. On the left-hand side, it will give you the most commonly tested concepts of that disease, and you'll get immediate feedback on these. You can take this an unlimited amount of times. This is an example of what the didactic level test would be. I try to make these a little bit easier to kind of design to be at the level of your in-class exams. You'll have 4 answer choices and you will get an answer explanation for anything that you happen to get wrong so you don't get it wrong on the actual test. This is an example of the board level test questions, so much more in-depth, 5 answer choices, and then that challenge level is up to the level of the PANCE or the PANRE. Again, you'll get the answer choices emailed to you, or the ones that you have incorrectly answered emailed to you so that you can not get those wrong on the actual boards. So thank you for watching, and I hope that this helped you, and I hope to see you for the second part of this video. Our legal disclaimer and our references: this is not designed to be medical advice. This is used for educational purposes only. All of our pictures are royalty free and they are attributed to their appropriate authors. And I look forward to seeing you for the second part of this video. Thanks for watching.